today we are interviewing Dr. Mark Ribo. He's a very well-known neurologist dedicated to neurointervention that you probably know from a lot of trials. And I had the pleasure to work with him for 6 months in the Vall d'Hebron stroke unity in Barcelona, where he works. And he's specially dedicated to neurointervention. So, hello, Mark.
Hello, the pleasure was ours to host you, of course, Maria.
Thank you so much. So this interview is centered in some of your formation and also on the subject that you are presenting in this conference. So I'll start by asking something that I've already asked before. Do you think there's advantages of being a neurologist performing neurointervention?
Sure, of course. I think there's advantages for neurologists to do it because it, at least in my case, it helped me fulfill the wish, the internal wish that I had to try to help a step further the patients. But in the context of the team, I think it makes a lot of sense to have a multidisciplinary team doing interventions. It enriches the team that you have. You can have interventionists coming from different fields such as neurology, neurosurgery, and obviously radiology. At the end, everybody brings its own experience, and also it creates a better workflow of ideas. And in the daily practice, it's we felt that it facilitates things if we are all involved.
Of course. And when you started in neurointervention, it was because of a need, right? It wasn't your initial plan, or what was it?
Well, so my personal experience was that we were starting to treat patients with IVTPA, and we were monitoring recanalization with TCD at that time. We were doing what we call the sonothrombolysis, and it was great when we could see how the clot dissolved and the flow on the screen with the TCD could improve. But it was very frustrating to see how, in those cases in which we did not have active recanalization, how the patterns of the flow were still pathological, and you felt like the thrombus just needed to be taken away. So to get rid of this frustration, I decided I needed to become an interventionalist.
Okay. And what would you suggest for training for neurologists and other physicians that want to do in neurointervention? Because now there are some, not guidelines, but orientations or requirements to be a neurointerventionist.
So I get many, almost every week, people contact me to find out about how they can get trained, and I think it's obviously difficult to find sometimes somebody that will properly train you. It's going to take at least 1 year, if not 2, to get fully trained. I think what you need to do is to show a great interest. What I usually suggest is to people that they will stay with us for before training. We get to know them, and once and that way, if whoever is going to train you knows you for a long period and understands that you are really encouraged and involved and interested in getting trained, it's going to be easier for you to be selected in a program as a trainee. So my suggestion is, if you want to train in an institution, make it happen that they know you well over a longer period, not just with an email. Otherwise, it's going to be difficult.
Okay, of course. So, Mark, I'll ask you a few questions regarding your presentation. You'll present on Friday at 10 a.m. Selection based on CT.
Yes.
Okay. And so I'll ask a few questions that are the doubt of every day. So do you think, it's just your opinion, if plain CT without any advanced imaging will be the future for selecting patients beyond 6 hours?
I think it's possible. I think contrast will be substituted at some point, either by nothing, just plain CT, and if you do direct transfer to angio suite, you can confirm your occlusion with an angiogram, and the measurement of the core might be not really needed if we confirm in the trials that are going on that the large aspects are also benefiting from endovascular procedures. And also there's the solution of the artificial intelligence. It's a way, I think it's a great way to substitute contrast imaging either to diagnose an LVO on non-complexity, but also to assess and measure the the initial core, or the predicted infarct that can also be done with AI, and it's going to be probably substituting contrast imaging.
Okay. So, and regarding your works about ghost infarct and also about the estimation of the core in perfusion CT, what is your opinion about this? Because some people would be influenced in using just the CT and not to use the perfusion because of this potentially excluding patients with this.
I think this is very important. If you're going to use perfusion imaging to select patients, you need to understand very well what you are seeing with these maps. Mm-hmm. And I do think CT perfusion is very useful in the early time window, of course, but not to not select patients, to unselect patients for treatment. I never use the core estimation in the first 6 hours to deny endovascular treatment to a patient, and that is how we should do it. There's no guidelines tell you that to use that in the first 6 hours. What the CT perfusion maps are useful for in the early time window is to detect mid to distal occlusions that sometimes can be foreseen on unadverted on CTA, especially in acute conditions, assessment of CTAs in which you can miss an M2 occlusion that might be tributary for endovascular treatment. CT perfusion maps helps you to depict these lesions and to decide if you want to treat them or not. So again, CT perfusion in the early time window is a great tool to include more patients, but never use it to exclude patients due to large core.
And in the after 6 hours, you don't see this ghost infarct or overestimation. It's less probable, right?
Yeah, the ghost infarct relates to the overestimation of the core seen by CBF flow on the usual thresholds for CBF. If those estimate a potential final infarct volume based on average numbers of time from onset to imaging and time from imaging to reperfusion. However, if you perform imaging very early and on top of that you recanalize that patient very, very fast, those predictions are going to overestimate the final infarct, and therefore this is what we call the ghost core, but it does never appear on a follow-up imaging. So again, but this doesn't happen on CT perfusion maps acquired after 6 hours. At that point, it correlates pretty well with the final infarct volume, and you can rely pretty well on those images, or CTP images, to confirm or to predict the final infarct.
And what the parameters, what do you prefer, to select the penumbra and to select the core?
No, I think the validated parameters, CBF less than 30%, are fine for beyond 6 hours. If you really want to use them, well, we should validate that, but probably if you want to use it within the first hours, we're going to need to lower the threshold or to change it to lower perfusion threshold that will predict. But this is not fully validated yet. Anyway, I don't think it's really necessary a CT perfusion maps in the 6 hours window to unselect patients for treatment. And as I said, probably in the near future, it's very likely that a plain CT will be enough, and aspects will be enough just to select patients even above beyond 6 hours.
Okay, Thank you. And regarding the patients that are borderline, that right now we are not treating within the criteria, for example, aspects of 4, 5, and because it's a subject evaluation, would you confirm it with an advanced imaging, for example, CT perfusion or an MRI?
So it depends on the availability and the timing, always. So I like to say this, like what this a lot. Everything has a price in life, and and you want nice images, you have to pay a price, which is time. So if you want an MRI, which is great to depict the infarct extension, it's great, but you pay a price, which is time. Is it really worth to pay this time? You need to decide. And my thinking is that most of the times it's not necessary, and the price you're paying is just it's going to be harming the patient. You just can take the same decisions with less imaging, faster imaging, and saving time. But it's all about the price you're willing to pay, or the patient is willing to pay.
Of course. But for example, these patients you wouldn't treat, for example, with an aspect of 4. Would you do anything to confirm?
Yeah, there are aspects of 4 and aspects of 4. So again, aspects can be there is a wide interobserver reliability. I think it will also depend on the previous status of the patient, his age. Very older patients with quite reduced infarct volume, spinal infarct volume will have very bad outcomes. But in general, I would promote enrolling these patients in the ongoing clinical trial. We participate in one of them, so we enroll these patients in trials. If we were not enrolling them, I would be eager. I would tend most of the times to treat aspects of 3 or 4, unless those are very old patients with lots of comorbidities.
Okay. And regarding the M2 occlusions, are you following for example, with the rules of perfusion, you follow the cutoffs, for example, of the studies to include, because the volumes will be different and the reason will be different.
To select the patients according to the established damage or the extension of the early signs, you mean, or the but yeah, yes. Sure, you need to reassess according to the final extension of the if you have a perfusion map, you have very well depicted your how do you say, your mismatch area, right? It's not you should if you don't have a CT perfusion, you can depict the perfusion territory according to where you located the occlusion, to which branch is occluded. Then you take into account in your assessment what is the NIH of the patient, the neurological deficit, and here for this kind of occlusion, the risk benefit ratio is shifted. So always when we perform a thrombectomy in a more distal vessel, we need to be extra care in not causing any harm. We should probably not be as aggressive in our procedures, and keep always in mind that the patient has a different risk ratio benefit. And on top of that, there are ongoing trials that are going to start. Again, trials that are going to bring us definitive evidence with randomized trial in which we're going to be randomizing patients with distal vessel occlusion into best medical treatment or endovascular treatment. So okay. that would be great too.
Okay. And again, in patients, other question, in the patients that are transferred between one side to another in drip and sheet model, how many hours do you wait to repeat for example, 2 hours, 3 hours? You don't repeat it at all?
Yes. I would tend not to repeat at all, unless at the previous site the aspect score was really borderline, like 5, 6, and a lot of time was elapsed. But otherwise, I would do as much as possible direct transfer to the angio suite, not repeating imaging, unless there is also a dramatic change in the neurological status, either improvement or clear worsening. But if the patient is basically the same with the same neurological deficit, and yeah, there's not a huge amount of time that was elapsed, I would not repeat. It's just a waste of time.
But how much would be the cutoff of the?
I don't think there is a rule. As I say, according to the initial aspects, we did a study in which we thought we demonstrated that most of the you never make a different opinion if the initial aspects was above 8 and the NIH was below 15. Very severe strokes with NIH is very high of 20, and an aspect that already decayed below 8, so 7 or less. And in these patients, the rate of deciding not to treat after repeating the image was slightly higher. So you could use this rule if you really want to repeat only when the NIH is above 15 and the initial aspect score was below 8. In that patients, it might make sense to repeat imaging.
Okay. And regarding, we still don't know the results of, maybe you do, of the Swift Direct and the presentations that will be due tomorrow, but also regarding the race cut that you've done in Catalonia, what would be your guess about the Mothership and Interventionist model in the future era?
No. Okay. So in RaceCat, what we observe that basically with the degree of selection that the paramedics can perform with the RaceCat, you can scale. You cannot select a population that benefits better from Mothership or Interventionist. And because of that, we just decided to bring all our patients to the Interventionist model. So we keep the expertise of these centers that performed very well in the RaceCat trial. So that is. We are building an AI-based algorithm that can detect a portion of this patient that will benefit from Mothership transfer. We can select up to 30% of these patients, and we're going to validate this model. The Swift Direct trial was about answering a different question. What do the patients that get to a comprehensive stroke center, can we skip IVTPA if they are eligible and they can receive a thrombectomy immediately at the same time? And the results show that there's no evidence to not to give TPA in these patients. So basically, we need to see the details of the publication, but basically the take-home message is that you probably should continue to give IVTPA in these cases because it's according to the results.
Yes. And just a final question, because you have organized a lot of trials, and HyperAcute trials, can you say the difficulty in including these patients in these trials?
Because again, can I say what?
The trials of HyperAcute phase, because the patients can't give informed consent, and the timing and the logistics and the organization. Can you comment on these difficulties?
Yes. Well, that's a problem for HyperAcute. For example, for the AngioCat trial, in which we had to randomize the patient right on arrival, either to go directly to the angio suite or to the CT scan. There was no time to explain either to a family member or obviously to the patient. So we were lucky enough that our ethics committee understood the problem and allowed a deferred consent, meaning that we were just randomizing the patient on arrival. And what we did is when the HyperAcute phase was over, we asked the patient or the relative the permission to use the data. And 99% of the times, if you explain it well, the family will give you permission to use the data. But you need to negotiate with your ethics committee in these conditions. That you need to make them understand that it makes otherwise impossible to perform such a trial if you need to give a properly and informed consent that takes at least 5 to 10 minutes. to explain well.
Yes, of course. Well, Mark, thank you very much. I hope we didn't take we didn't to lose plane due to this interview.
Great.
Nice to
hope
see you.
You could hear me well, and I hope
Yeah.
I can see you also very soon. Thanks a lot.
Thank you very much, Mark.
Bye, Mariana.